Our next speaker, we're really lucky she's here because we don't get a lot of interaction with pediatric hepatologists, and that's exactly what she is. Molly Bozic is an assistant professor of clinical pediatrics, and she's been here at IU as a pediatric hepatologist since 2012. She has special interest in peds liver disease, but also in cystic fibrosis change with the liver as well. So she's going to be enlightening us with a talk entitled AIH, Pediatric Challenges and Overview. Thank you, Dr. Bozic.
Thank you, Dr. Lamert, for having me today. It's a great opportunity to get to speak to hopefully some parents out there and even the adults who may have kids that are affected with autoimmune hepatitis. So what I'm going to do today is just to provide a little bit of an overview of pediatric AIH. And some of this will be a little bit of overlap, but there are some unique findings specific with pediatric disease. We're going to talk a little bit about differences between pediatric and adult autoimmune hepatitis. There's various presentations of pediatric AIH that's a little bit different than adult, so we'll talk about 3 different modes of presentations that we'll see in kids. We're going to look at some of the difficulties and challenges in pediatric autoimmune hepatitis, ranging from compliance with medications, some of the side effects with medications, et cetera. And then one of the things that we're experiencing in our pediatric population now that as physicians I don't think we do a very good job of, that we're working on improving, is how do we prepare our young kids and teenage kids for transition to the adult world. So as we know, autoimmune hepatitis, it's a condition where the person's immune system attacks the liver, causing progressive inflammation in the liver. And if left untreated, the inflammation can lead to cirrhosis or scarring of the liver, and sometimes even liver failure, which can be fairly rapid in the pediatric population. So presentation in kids compared to adults often presents much more acutely than in adults. And in pediatric cases, it's usually more of an aggressive form of the disease early on than what presents in middle age or in elderly patients. So there's 2 main types of pediatric autoimmune hepatitis, which you've heard about already in this talk. So type 1 is associated with autoimmune anti-smooth muscle antibody, and type 2 is an anti-liver kidney microsomal antibody, which is quite rare in adults but more common in children. So for type 1, again, this is characterized by elevated liver enzymes and the autoimmune markers with a positive ANA and a positive smooth muscle antibody, and is just in adults, elevated IgG levels. As you guys well know, type 1 is common in adults, but also affects about 2/3 of the pediatric patients. This type of autoimmune hepatitis usually presents around puberty in kids, and this type is more common to have higher levels of bilirubin and transaminases, or the ALT and AST, at the time of presentation. This type of autoimmune hepatitis in children is more frequently associated with a fulminant hepatic failure, and progression to cirrhosis during treatment is more common in this type of autoimmune hepatitis in kids. As we all know, autoimmune disease with the liver, you're at risk for other autoimmune diseases. And about 20% of kids with autoimmune hepatitis type 1 have other autoimmune diseases, whether it be diabetes, inflammatory bowel disease, autoimmune thyroid disease, so things that we are watching for closely as we're monitoring our kids. So type 2, much less common in adults, and this is where you'll have positive antibodies to liver kidney microsomal antibody, and IgG levels are elevated in about 75% of patients. Again, this is mainly a pediatric problem, but there are cases seen in adults. And this accounts for about 1/3 of the pediatric cases. Compared to type 1, which I had talked about presents usually in puberty, this type usually presents at a much younger age, and there's even been cases of autoimmune hepatitis type 2 in infancy. And similar to type 1, about 20% of these kids will have other autoimmune diseases at some point in their lifetime that requires close screening. And then there's another form in pediatrics that I'd like to talk about is autoimmune PSC, and it's been talked a little bit about in the conference as part of the overlap syndrome. So Autoimmune PSC in kids typically has laboratory and histology findings that are very similar to autoimmune hepatitis, but also has evidence of bile duct disease, specifically sclerosing cholangitis. This affects boys and girls equally, unlike type 1 or type 2 autoimmune hepatitis, which is predominantly a female presentation in kids. Autoimmune PSC requires additional imaging with an MRI that can show abnormalities in the biliary system. And just like type 1 and type 2 autoimmune hepatitis, it typically responds to immunosuppressants, but also requires other medications such as ursodeoxycholic acid or URSO in short-term use. Unfortunately, autoimmune PSC has a worse prognosis than the classic type 1 and type 2 autoimmune hepatitis in kids. So how does it present in kids? So there's 3 patterns of presentation. Most commonly is an acute presentation where about 40% of patients will present with a viral-like prodrome or a viral hepatitis, where it's acute or sudden onset of fatigue, nausea, vomiting, jaundice, dark urine, pale stools. With the acute presentation, some pediatric patients will go on to acute hepatic failure within 2 to 8 weeks from the onset. That's more commonly seen in type 2, but fairly rare. There's also a more insidious or slow onset, where about 25 to 40% of pediatric patients will present with just progressive fatigue, headaches, malaise, anorexia, have very short or recurrent spells of jaundice. And this sometimes can last several months or years before a diagnosis is made, because sometimes the symptoms are relatively mild and will be dismissed as sort of a viral illness that patients will have symptoms and then resolve and then will have recurrent symptoms. And then unfortunately, some patients will present with end-stage liver disease. Well, they'll present with signs or symptoms of significant scarring in the liver. So when patients sometimes will present with portal hypertension, where the liver is so sick that the blood can't get through the liver, and they'll present with things such as variceal bleeding or vomiting blood. Sometimes these patients have no history of jaundice or other problems. They frequently have enlarged livers or spleens on exam. So some of the physical exam findings that we will look for in pediatrics that are signs of underlying chronic liver disease. And the picture up on the left is called a spider nevi, and it's a sort of capillary abnormality that's seen in chronic liver disease. Sometimes the palms of kids will be very red, called palmar erythema. Obviously, as you know, having jaundice or sclerolicterus or yellowing of the eyes. And then on exams for the pediatricians, sometimes we will get kids referred to us that on just their routine child exam will have an enlarged liver and a spleen that sometimes can be a clue to autoimmune hepatitis or other forms of liver disease. So how do we diagnose it? In kids, it's very similar to adults. Blood tests will usually see elevated transaminases, so AST and ALT, which is a sign of inflammation in the liver. We're looking at those autoimmune markers, so the most common being ANA, LKM, and smooth muscle for type 1 and type 2 respectively, or type 2 LKM and type 1 smooth muscle. We also look at how the liver is functioning for those patients that may be presenting in liver failure, so looking at markers of coagulopathy, so PT and INR, or albumin, which is a sign of how the liver is functioning. And then obviously we're ruling out other kinds of liver diseases that kids can have. So we'll rule out viral hepatitis, so ruling out hepatitis A, B, and C. Looking at Wilson's disease, a problem with copper in the liver, alpha-1 antitrypsin. So all the other common problems that are seen in pediatric liver disease, we want to be able to rule those out. We also do some imaging. This image doesn't project very well, but if patients have an enlarged liver or spleen, looking at either ultrasound, CT scan, MRI, or other measures to look at how the liver, making sure there's no masses in the liver. Sometimes on imaging, in this ultrasound, I have a pointer. Here you can see the edge of the liver is very nodular or sort of bumpy, and it should be very nice and smooth. And when we see that nodular edge of the liver, that's sometimes a sign of more progressive liver disease or the cirrhosis or scarring in the liver. Just as in adults, we look at liver biopsy. We'll see signs of inflammation in the liver, and I know you've had a talk on this earlier. We'll see increased number of white blood cells, specifically lymphocytes and plasma cells. And typically when it's just autoimmune hepatitis without that primary sclerosing cholangitis, we'll see intact bile ducts without scarring or problems with the biliary tree. So goals of treatment in kids, one is to improve the liver inflammation, try to induce remission, improve symptoms, and prolong survival, similar to adults. So in kids, again, the mainstay of treatment typically is steroids with prednisone, and usually are started initially and are on for about 4 to 8 weeks, and then the dose decreased as the liver enzymes continue to improve. In pediatrics, many of the patients are continued on a maintenance dose of steroids, but we try to get that down to the lowest dose of steroids possible, usually 2.5 to 5 milligrams a day, to try to limit the side effects. Steroids, other steroids such as budesonide, which was mentioned a little bit earlier, is sometimes used in very mild disease. There's not a lot of evidence yet to support its routine use in pediatrics, but the nice thing about budesonide is it doesn't have all the side effects associated with prednisone, particularly things such as stunting growth in kids. And then, as you know as well, using immune modulators or azathioprine. In pediatrics, this is required usually in about 85% of patients. And there's a little bit of variation in using azathioprine, whether it's used initially up front or if it's added on if we're not seeing response to steroids. The vast majority of kids in our center are typically on azathioprine because we're trying to get the kids off of the steroids to limit the side effects associated with it. So what's the prognosis in kids? So cirrhosis or liver scarring, interestingly, is present in about 45, sometimes up to 80% of children at the time of diagnosis. So it's a more progressive, more rapid disease, and we will typically be seeing kids with more severe disease even at diagnosis. Fortunately, mortality in kids is really quite low, and kids usually become very stable with a good quality of life, but do require long-term treatment. So this is some data from Dr. Miele Vergani from King's College, and looking at comparisons for autoimmune hepatitis type 1, type 2, and autoimmune sclerosing cholangitis. So when you're looking at remission rate, type 1 is the most successful with steroids and or azathioprine, upwards of 97%. As you can see, the autoimmune sclerosing cholangitis, a little bit worse prognosis with remission rate only in about 90%. The time it takes to get to remission, interestingly, is less in the autoimmune sclerosing cholangitis with about 2 months, and sometimes can be up to 9 months in patients with type 2 autoimmune hepatitis. Relapse rates are quite common in kids, sometimes requiring increased dose of steroids to get them back into remission. We always are talking, especially in kids when we diagnose them early on, can we get them off of treatment because they've got a lifetime of, to be on medications. So in this study with type 1 autoimmune hepatitis, about 19-20% of kids were able to get off of treatment. Type 2, that was not the case, more a severe form of the disease, and only about 5% in autoimmune sclerosing cholangitis. We think about what's the prognosis for liver transplant in pediatrics. The highest rate of transplant is in that autoimmune sclerosing cholangitis, upwards of about 25%. Unfortunately, in type 1 and type 2, in this particular study, in some patients that are transplanted, there's increased risk of increased risk of the autoimmune hepatitis coming back in the transplanted liver, less common in type 1 and type 2, but more common in that overlapping autoimmune sclerosing cholangitis. So just a little bit about transplantation in pediatrics. Transplantation is obviously for patients who present with fulminant liver failure and those who develop end-stage liver disease and significant complications of that liver disease. And there's studies that quote about 10 to 20%, 20% being rather high, usually more close to 10% of patients with autoimmune liver disease requiring transplantation in pediatrics. There are rates of about 20% of recurrent AIH after transplantation, and sometimes that can occur several years after transplantation. Sometimes these patients requiring higher dose of steroids than patients who required liver transplantation who didn't have autoimmune hepatitis in kids. So what are some of the challenges in pediatric autoimmune hepatitis? One of the biggest challenges we face is compliance, especially with our teenage kids. In the teenage years, kids are becoming more independent. Sometimes when they're in remission, don't have symptoms, so kids not understanding why they need to take medications if they feel well. So regular adherence to medications is really important to maintain remission and prevent further scarring of the liver. Side effects of medications such as the prednisone is really difficult for our teenage kids. So a lot of times getting acne, the weight gain, increased appetite, the moon faces where their cheeks become very swollen, our teenagers hate it and don't like to be on prednisone. So another reason why we try to get prednisone down to the lowest dose possible as early as possible and using our other medicines such as azathioprine. Again, prednisone side effects. One of the things that we worry about in our little kids is issues with growth. So one of the biggest side effects with long-term treatment of steroids, especially at high dose, is impacting linear growth in kids. Fortunately, when it's very low doses, the 2.5 to 5 milligrams maintenance dose, that does not have an impact on kids' long-term height. It's more the higher doses that you're initially started on to get into remission. So we try to get those doses down as much as possible. In pediatrics, with our females, we worry about pregnancy, just given the teratogenicity associated with the medication, and really focusing early on about birth control and having our teenage girls sort of understand the risk and making sure that they're protected. Other difficulties with autoimmune hepatitis in kids is looking for other autoimmune liver diseases, specifically in patients with autoimmune PSC, monitoring for inflammatory bowel disease, upwards sometimes of 20 to 40%. So looking for signs of diarrhea, weight loss, blood in the stool, unexplained abdominal pain, or poor growth. And then one of the things I wanted to focus on last is how do we transition our kids to adult care, and how to prepare not only our kids but our adults for making that transition. Achieving independence requires an organized transition process to gain independent healthcare skills, prepare for an adult model of care, and transfer to new providers. And when we have our little kids that are diagnosed at 5, 6, 7, 8, and we're following these kids until they're 18 or 20, sometimes that transition can be quite scary and difficult, and we want to be able to prepare our families, and as physicians we need to do a better job of preparing kids for transition. So I included a little bit of a timeline here, and there's lots of research out there, and the American Academy of Pediatrics and some resources on how and when do we start transitioning kids to adult care. And it really starts fairly young. So even at age 12, that physicians should, and if they're not, having patients and families talk to their providers about what their policies are. Sometimes pediatrics will follow kids through their first year of college up until 20. Sometimes the cutoff is 18, and so we want to be prepared for that, and talking about that earlier on is important. By age 14, we're talking about implementing transition planning. So we'll talk with our kids about what their medications are, getting them to answer questions in clinic. At age 16, really talking about preparing youth and parents for adult model of care and discussing the time of transfer. So at age 16 to 18, we're talking about having the parents out of the room at some point and having the kids answer questions and going through their concerns with some independence without the parent in the room, and then bringing the parent back into the room. Typically at age 18, we're essentially modeling that adult model of care, and then usually transitioning anywhere from 18 to 22. And then I've got a few slides coming up just on ways that how can we prepare our families and our kids for this. So first, discovering, learn about your doctor's approach to transition. Hopefully your doctor is talking about it, but again, pediatricians a lot of times don't want to let go of their patients, so it's important for families and patients to bring that up early on. So why, if they go to a pediatric doctor, why do we have to change is a lot of times the questions that we will get. That we're trained pediatricians to care for infants, young children, and young teenagers and young adults. But as you guys know, adults have other healthcare problems that you want an adult provider taking care of. What should I be asking my pediatric doctor about transition? You want to ask if there's a policy in place. You don't want to come to find out at age 17 that within 6 months you're going to be transferred and did not have that information up front. When will that transition occur, and how do we prepare for that transition? So just looking at early on with diagnosis when that transition is going to occur. It's important for kids and families to track their own healthcare data, and how can we help kids do that? Sometimes we'll use apps on the phone to help kids track data. encourage kids to write down questions. We encourage families, and we will do binders and things for families to organize their lab results and their imaging results and their liver biopsy results, and starting that early on helps create independence later on. We emphasize what's important to bring to appointments, bringing questions, bringing insurance cards, all those things that as adults we sort of take for granted that kids just don't know about, and if we don't prepare them early on, it makes that transition much more difficult. How do I learn to manage your own health care? At what age should you start thinking about it? Really early on, typically in 12, 13, 14 years of age. How do I become more in charge of my own health care? It's not uncommon where I will see a patient in clinic and they're 17 and the parents answer all the questions, or the kids will look to the parents when you ask about belly pain or their symptoms, and the kids look to the parents. And so it's our job sort of early on to get kids comfortable where we engage them in understanding their bodies, understanding their symptoms, so that that transition happens much better. And I think one of the most difficult things, not only for the patients, but for the parents and even for the providers, how do we let go of our kids? And I think, again, starting that early on and encouraging kids to take advantage of opportunities to work on transition skills. Getting ready for adult healthcare, some questions that you need to ask. What legal changes do we need to know about? If my child needs help with healthcare decisions, what are our options as parents? When kids turn 18, even when they're followed in pediatrics, we have to discuss those healthcare findings or their lab results or their treatment options with the child, and it's up to them. But how do we create that environment where the parents still have a say? We talk about how do I find a new doctor and how do they know if it's a good fit for me. In pediatrics, a lot of times we will help because we know the adult providers here in the city or throughout the state. And a lot of times we'll ask our adult providers to meet with our families and our kids before we actually transition them, just to sort of establish that, that care, understand sort of personalities. And so it's, they've already met with their provider before that they actually transition care. And it can be quite stressful, again, not only for the patients, but for the parents and for the providers as well. And so again, making sure that there's open communication with patients, families, and their physicians on addressing their concerns and needs. Actually transferring, I think one of the most important things is what information does my current doctor need to send to my new doctor? We try here at Riley is we have medical summaries that we start at age 12 in patients that have chronic liver disease or other chronic diseases. Well, we will keep track of procedures, time of diagnosis, medications, problem with medications. And so that at age 18 to 20, that we have a good summary that we will be able to provide not only to the new provider, but to the family. And it's okay for families to ask for that medical summary that they can keep with them as well. How is adult care likely to be different than pediatric care? A lot more independence and sometimes less hand-holding, where patients are more responsible for making appointments and keeping those appointments. And if they need to reschedule the appointment, the office may not necessarily be calling multiple times saying, where are you, we need to get you in. And just improving independence with kids and responsibility for their own medical care. There's a couple of resources that I put on here that are great if there's anybody out there that has families or kids. There's a website called Got Transition, which is supported by the American Academy of Pediatrics. It's a great website, and it has information for both the kids and the parents, and it has lots of tools and worksheets that are used to help prepare kids for transition. And the American Academy of Pediatrics at aap.org is another good resource for families to go to. One of the things that I did just a screenshot for, that there's great tools for kids that go through checklists that start at age 12, 13, 14 that you can use to take to your appointments. If your physicians aren't using them, you can take them there. And it'll ask questions, what are my symptoms, including ones that I quickly need to see a doctor for? Do kids know this? Is it something that they're aware of, or is it something that we need to work with them on? So just great resources for kids and families to use at some of those websites. So just in summary, autoimmune hepatitis in kids is a liver disorder that's type 1 and type 2 most common. Type 1 is seen in adults and children, and type 2 is primarily a pediatric disease, although there are cases of adults. Autoimmune hepatitis is quite progressive in kids early on, with many of them presenting with cirrhosis at the time of diagnosis. Prompt treatment with immunosuppressants is really important to prevent the advancement of disease. Fortunately, with appropriate treatment with steroids and azathioprine, about 80% of pediatric patients achieve remission and have long-term survival with their native livers. Remembering about that autoimmune PSC looks very similar to type 1 autoimmune hepatitis, but has bile duct disease and has a worse prognosis and higher transplant rate than classic autoimmune hepatitis in kids. Many challenges in pediatric autoimmune hepatitis, compliance being one of the greatest. Having open communications with your liver doctor can ease challenges associated with chronic disease in kids, and really taking home that it's important to prepare for transition early in those teen years, so that transition can go more smoothly in the 18 to 20 year of age. So.